So in this first section regarding peptic ulcer disease, we'll be studying about different things such as the epidemiology, the causating factors, the etiology, and different types of ulcers. We'll be studying about refractory ulcers and stress ulcers. So as peptic ulcer is being divided into two types of ulcers, one being the gastric ulcers and the other being the duodenal ulcers. Gastric means that the ulcers are present within the stomach, and duodenal ulcers that it is present within the duodenum. So if we talk about the epidemiology, there's been remarkable changes in the epidemiology of peptic ulcers in the past 2 centuries. So if we talk specifically about the gastric ulcers, there was a peak in the incidence of gastric ulcers in the first half of the 19th century. And then if we talk about the second half of the 19th century, duodenal ulcers arose and they had the most peaked incidence. So if we talk about Helicobacter pylori infection, it is usually acquired during the childhood and it manifests as peptic diseases in the later ages when the child has grown up and probably in the adult life. So if we talk about the incidence of duodenal ulcer and the gastric ulcer, it usually declines with the decline of the Helicobacter pylori infection. So this is usually because of improved sanitary conditions and improved water and food supply. So based on the physician's diagnosis, the annual incidence of peptic ulcer disease is around 0.14% to 0.19% specifically in the developed countries. And if you talk about the geographic variation, there's a very wide geographic variations in the prevalence of peptic ulcer disease. And the annual incidence of bleeding, which is a complication of peptic ulcer disease, among the population was around 19 to 57 per 1,000 individuals. So bleeding is the foremost, most highest contributing complication regarding peptic ulcer disease. And if we talk about a different complication, there is perforation, which also occurs as a complication of the peptic ulcer disease, and the incidence of perforation is around 4 to 14 in 100,000 individuals. So if we talk about etiology, the causes of peptic ulcer disease, the prime and the highest risk factors regarding peptic ulcer disease is of Helicobacter pylori infection, and second being the use of aspirin and NSAIDs. And thirdly, the most highest number of peptic ulcer disease, which is nowadays, which slightly is growing, is the idiopathic ulcers, which is also known as the HP negative and the NSAIDs negative type of ulcers, which does not really have a cause. So if we see in this pie chart, there's a comparison between the duodenal ulcers and the gastric ulcers. So in both of these peptic ulcers, Helicobacter pylori infection is the major cause of these ulcers, and second being the NSAID use and the aspirin use. But if we compare duodenal and gastric ulcers is more prone because of the use of NSAIDs and aspirin. Other than that, there are other factors regarding the causing factors of peptic ulcer disease is Zollinger-Ellison syndrome and other unknown factors that causes peptic ulcer disease. So if we talk more specifically about the Helicobacter pylori infection regarding peptic ulcer disease, the Helicobacter pylori infection nowadays is declining. So the fact that Helicobacter pylori infection is declining, the peptic ulcer disease is also declining. But still, Helicobacter pylori infection remains the most major cause of peptic ulcer disease worldwide. If we talk about the prevalence within different countries, USA and the European countries have the lowest prevalence of peptic ulcer disease due to the fact that Helicobacter pylori infection in these countries are very low. So if we talk more specifically about this infection, it causes an antrum type more predominant type of gastritis. Antrum is that it involves the part of the stomach which is the end part of the stomach, which is called as antrum. The incidence of antrum type of gastritis is around 10 to 20% in a population. So this antrum type of gastritis, it causes high gastric acid secretion, which ultimately causes an increased risk of duodenal ulcers. So what really happens is that this high type of gastric acid, which is produced within the stomach, as in this picture, gastric acid is produced within the stomach, and it is being uh, transferred into the duodenum. So this acid load, which is an increased acid load, which occurs and which enters the duodenal part of the small intestine, it causes injury to the mucosa of the duodenum, and it causes duodenal ulcers. Other than that, there's a pan-gastritis, which involves the antrum part of the stomach and the fundal part of the stomach. It causes lower gastric acid secretion, which predisposes to more gastric ulcers. So the part of the stomach, it is normal to have a high amount of acid, which usually prevents any type of gastric ulcer to occur. But in pan-gastritis, what actually happens is that there's a decrease in the gastric acid, and it makes the stomach and the mucosa of the stomach more prone to develop a gastric type of ulcer. So the second type of causating factor of peptic ulcer disease is the use of aspirin and NSAIDs. As aspirin is being widely used within the population of the world, and around 11% of the population of the US uses aspirin on a daily basis. So the regular use of NSAIDs causes an increased odds of gastrointestinal bleeding, which is up to 5 to 6 folds. So the whenever there's a person who uses aspirin or NSAIDs more regularly, the patient is more prone to develop upper intestinal bleeding, which is after developing a gastric ulcer. So this usually damages the mucosa by the suppression of prostaglandin synthesis. So what exactly happens is that as aspirin and NSAIDs, they are COX inhibitors. So this COX inhibitors inhibits COX. So what does COX really do? It helps in the synthesis of prostaglandins, which ultimately helps in the defense mechanism of the stomach or the duodenal mucosa. So this NSAID, when taken as it is a COX inhibitor, it suppresses the formation or the development of prostaglandins, which ultimately then causes a weakness in the mucosa, in the defense mucosa. So there's a third type of ulcers, which is called as idiopathic ulcers. So this type of ulcers is slightly increasing. It is Helicobacter pylori negative ulcers and NSAIDs negative ulcers. It means that in these type of ulcers, it is not because of the infection or because of the ingestion of these type of medicines. So these type of ulcers, they're slightly increasing. Patients with idiopathic ulcers is around 20 to 30% in the US. So the high incidence of recurrent ulcer bleeding. This type of ulcer is more prone to develop gastrointestinal bleeding within the stomach. So if we talk about different types of causating factors of idiopathic ulcers, cocaine, the ingestion of cocaine and the use of cocaine causes multiple ulcers within the stomach and the duodenum. The use of bisphosphonates, for example, in patients such as osteoporosis, these bisphosphonates are also, they also develop different type of gastric ulcers within the stomach. The use of glucocorticoids, which are steroids. The use of steroids and NSAIDs as a combined effect causes more different types of peptic ulcers within the stomach and the duodenum as compared to NSAIDs being ingested alone. The use of selective serotonin receptors, and the use of alcohol. And there are also some factors such as stress that can also cause these idiopathic ulcers. And lastly, smoking being one of the foremost reasons of different types of ulcers within the stomach and the duodenum. So there's a different type of ulcer called as the refractory ulcer. So what exactly is a refractory ulcer? What happens is that the patient has a gastric ulcer or a duodenal ulcer. So what happens is that after the treatment of these ulcers, such as the anti-secretory therapy, these patients still persist, and despite having this treatment, the patients still have these ulcers. So these ulcers are known as refractory ulcers, is that these ulcers, they are not being treated with the help of anti-secretory therapy or any other therapies or treatment of the peptic ulcer disease. So the symptoms of this refractory type of ulcer persist and may be very severe. The ulcers become asymptomatic and is usually only detected with the help of endoscopy. So a clinician, when a patient presents with a refractory ulcer, the clinician might ask different types of questions, such as, has the patient complied with the prescribed treatment? The second question might be, is the ulcer penetrating the pancreas, liver, or other organs? So that is why the refractory ulcer is not healing. The third question might be about that, is there a presence of Helicobacter pylori infection? Is the patient still taking an NSAID? In fact, being advised not to take any type of aspirin or NSAIDs, because these are also the causating factors of ulcers. And lastly, asking the patient whether the patient smokes cigarettes or not. So these type of ulcers are present despite the therapy, the anti-secretory therapy given to these patients. So the clinicians finally, they come to a point where they decide that this is a refractory type of ulcer. And the treatment of this refractory type of ulcer is that the patient is being given the anti-secretory therapy, which is given for a more prolonged time period, so that the patient, so that these refractory ulcers can heal. Finally, the second type of ulcers known as the stress ulcers. These stress ulcers are usually present in very critically ill patients who are usually present in the ICU. Minority of these patients usually present with gastrointestinal bleeding as a complication. There's always a respiratory failure or a coagulopathy type of strong risk factors related to stress-related ulcers. The endoscopic control of hemorrhage with proton pump inhibitor is the preferred treatment regarding stress ulcers. So the hemorrhage and the bleeding within the esophagus or within the stomach is being treated with the help of an endoscope. And after the patients are given proton pump inhibitors as an oral intake. And lastly, the patients might also be given IV histamine receptors antagonist and sucralfate as a prophylaxis to prevent these stress ulcers to occur in patients who are critically ill.